make a start.
Are you able to do that, Michelle?
It looks like it's started.
It looks like it's recording already.
Yeah, fantastic. Okay, thanks everybody. So you're really welcome to this NIHR National Cross-ARC Palliative and End-of-Life Care Collaboration webinar on the health and caregiving experiences of parents of children with a life-limiting condition. Can I have the next slide, please, Nick? So for anybody who's not familiar with the NIHR ARC collaboration, it was NIHR funded 15 ARCs running until March 2026, and their role is to conduct applied health and social care research, undertaking research where it's needed most. And this cross-ARC collaboration on palliative and end-of-life care is co-led by Professor Irene Higginson and myself. I'm Morag Farquhar, and supported by Meg Hopcock-Blue. The role of this collaboration is to drive collaboration, maximise impact, and provide expert advice where it's needed. So that's enough of an introduction about ARC. I want to move on to the most important part of this session, which is the presentations by our guest speakers. So I'm really pleased to welcome today Julie Russell, Victoria Fisher, and Lorna Fraser. So Julie's family used paediatric palliative care services at Christopher's Hospice in Guildford during their first son Fraser's life. The family have collaborated on a book about families' experiences with music therapy in children's palliative care settings, which came out in March. And Julie provides input into research through her role with family advisory boards at the Paediatric Palliative Care Research Group at University of York and at Cicely Saunders Institute at King's College London. So Victoria is a research associate at Cicely Saunders, and Lorna is Professor of Palliative Care and Child Health at King's and a current NIHR research professor. So we're going to hear first from Jules, then Lorna, and then Victoria. And you can post questions in the Q&A box. There's a link to it at the top of your screen, hopefully. And then we'll come to the questions at the end. So I'm going to hand over to Jules first of all. And we're really looking forward to hearing about the health and caregiving experiences that you've had. Thank you, Jules.
Hi, thank you, Morag, for that introduction. I'm just going to share my slides with you now. So yeah, thank you, Morag, for that introduction. And I'd also like to start by thanking Lorna for inviting me here today to share my family story and how in part it relates to many aspects of both Lorna's and Victoria's research. To convey this experience to you in just a few minutes is going to be a bit of a challenge for me. So I would encourage you to sort of save your questions about my story till later, if that's okay. I'm just going to see if I can move you on to the next slide, and I'll be happy to elaborate on them further. Okay. So our first son, Fraser, was born with a very rare inherited metabolic disorder. And this came as a complete surprise to us. He was born at our local hospital in Surrey, and although appeared without any issues for the first few hours of his life, then started to have problems with his breathing and deteriorated quickly, requiring specialist attention in the hospital's special care baby unit. This was a really stressful time for us, and we got little information as to how he was doing and what was going wrong. Within about 24 hours, he had deteriorated quickly, and so was transported to the neonatal intensive care unit at St Thomas's Hospital in London for life-saving care and an appraisal to see if he had a serious medical condition. After a few days, it was thought Fraser might have a rare inherited condition, but which one they couldn't tell. But under the amazing care of staff and the specialist paediatric teams, Fraser grew stronger and eventually left hospital after about a month and came home. As the months went on, it was clear that Fraser wasn't keeping up with other babies of that age, and after 10 months, we were told by St Thomas's that although they couldn't name his condition, it came under a group of severe and complex medical disorders that would end his life, most likely during infancy. There was no cure and only his symptoms could be supported. Fraser ended up having global developmental delay, muscle weakness throughout his body, 4 types of seizures, and would need support in feeding and later oxygen for breathing. He required 24/7 care. Fraser could react to his environment with smiles and animated movements and at times crying, but he was unable to speak and struggled to physically communicate through basic Makaton signs. We, his parents, felt we could understand his moods, but would really never know how he would truly feel or if he could comprehend what it was to feel and process his own feelings. At the time of having Fraser, I ran my own lighting design consultancy and lectured in design at a design school in London. As I was a freelancer, I had no one to take over my business when Fraser was born. My plan to return to work after 3 months of maternity leave became impossible, and I had to close my business and become Fraser's main carer. My husband continued to work, and his company was extremely supportive, but he inevitably lost out on progressing his career while Fraser was alive due to Fraser's condition, which led to many planned and unplanned hospital visits. Fraser required multidisciplinary care from a variety of services and practitioners. Many practitioners in our local area avoided getting involved with Fraser at first, as his condition was so rare. It was felt by them that only specialists at the top London hospitals could look after him. This simply wasn't true. Although his underlying condition was rare, the symptoms he experienced were similar to many babies and children with other conditions and could have been supported within our local authority and community. This meant I had no one to turn to locally for support. I had to try and manage all of Fraser's care on my own and get to grips with this new medical world that I had no experience in. We were never given a social worker for Fraser, so my husband and I had to spend the little available time around caring for Fraser, figuring out the system, what was Fraser's entitled to and what he wasn't. A huge pile of paperwork never reduced in the 2.5 years of Fraser's life. I recall one conversation on the phone to the local authority, trying to get a hospital-style raise and lower bed so he could sleep better whilst being hooked up to his feeding pump and receive medication overnight. We were told that there were sicker children in the authority that needed support, and unless we could tell them when he was going to die, they couldn't sign off any payments for him and the equipment he so desperately needed. They had turned our son's life into a competition with other families, and this was truly unacceptable. If it wasn't for a small flyer about a tiny local carers charity that I stumbled across on a hospital visit, I wouldn't have gotten the help we had needed to look after him. In fact, it wasn't until I read the description on the flyer about who a carer was that I realised I was one, not just Fraser's mum. Through them, they suggested that we might be able to be supported by our local children's hospice, Christopher's, now part of Shooting Star Chase, which was fortunately based in our hometown. From there, we started to get support from within the hospice. We could take Fraser to do various activities during the week, and that gave me some respite for an hour or two while he was there. They also provided a lot of support in filling the gaps in Fraser's medical care provision, like occupational therapy, that I was struggling to get for him within the community. I felt Fraser had somewhere to belong in this community, and that was very important to me. If it wasn't for Christopher's, I don't know how my family would have coped during Fraser's life. They provided so much practical and mental support for us all. They helped us live and were there when it came to Fraser passing and beyond. They plugged the gap of many services and support provision we should have had from our local authority, and it is sad to see this service now dramatically reduced due to funding challenges for the UK hospice network. I'll finish now by saying Fraser was an incredible boy, and mine and my husband's lives were greatly enriched by having him. He was the centre of our worlds, and we would never wish to have not had him. But what I would have changed were our struggles through a disjointed and complicated health and care system that has no clear path or agenda for supporting families with children with complex medical needs and are life limited. Too much of the care needed is ignored or pushed aside for others to deal with, like the fantastic charity-run children's hospices and other charities that provide carers for families in need. Too much of my time was spent being Fraser's life support system and an administrator to his needs, and not enough being his mum. As the reports find, we mums and dads happily put our children's needs before our own, but that doesn't mean we don't have needs as people in our own right. I'd very much like to see this change going forward. Thank you for listening.
Wonderful, thank you, Jules. So I'm going to hand over to Victoria, I think is going next, or Lorna, apologies, got your order wrong.
No problem. Thank you so much, Jules, for an excellent presentation and sharing your story and Fraser's and some beautiful photographs. I want to talk about a programme of work that actually arose from one of my very first conversations with parents at a local children's hospice, when I really first got a sense of the amount of caring and the struggles that parents often had in terms of getting the basic needs of their child met through our statutory system, and the impact that that was having on their own health and well-being. And as Jules says, they have, as well as being parents, they do have a right to their own lives and to be as well as possible. So there are about just under 90,000 children and young people living with a life-limiting or life-threatening condition in England, and it's often expected that parents become healthcare providers 24/7 for their children. It's predominantly, but not only, mothers that take on this role. We do work with some dads who have been the primary carer. And when we started this work, although there was some evidence about the physical and mental health of mothers of children with disabilities, there was little around the impact of having a child with a life-limiting condition where you have been told they're likely to die during childhood. So this was funded by the NIHR Academy, and there's 3 work streams. I'm going to talk about the first work stream, which was a secondary data analysis project, and then I'm going to hand over to Victoria to talk about work stream 2 and touch on our plans for work stream 3. Now, I'm going to be showing you some data that we collected within our National Health Service, but I would ask you to remember that behind every data point we have a mum like Jules or a child like Fraser. So what we wanted to understand was really what was the health and well-being of parents of children with life-limiting conditions. How was this impacting their own health, and how were they able to access care to support their own health and well-being in order to continue to care for their child? So we had data from the Clinical Practice Research Data Link that some of you may be familiar with. This is routinely collected data within our primary care systems within the UK, and we can have these data linked to hospital data. And we can, within this, we have the ability through pregnancy records to link between mums and babies. Unfortunately, we don't have an accurate way to link between dads and their children at present. And within these data, we were able to identify 3 groups of children and their mums, and that was children with life-limiting conditions, children with other long-term conditions that were not life-limited, and children who appeared to have no long-term condition from these data. And we had all primary and secondary healthcare data for these parent-child dyads. Working closely with our parent panel, they were keen that we looked at common physical and mental health conditions such as back pain, obesity, high blood pressure, as well as mental health conditions, anxiety and depression, and serious mental health problems as well. We were able to identify symptoms and diagnoses as well as prescriptions within the primary care data and diagnoses within our secondary care data. Because this is a longitudinal data set, we were able to only include those in whom they had a diagnosis or a record of any of these physical and mental health conditions after the birth of their child, or indeed for those who had a condition after their child had been diagnosed with a condition. So we had around 9,000 mothers whose children had a life-limiting condition, a similar number where their child had a long-term condition that wasn't life-limited, and double where the child had no long-term condition. And these groups were very similar, apart from that there were more mothers and children in the life-limiting group living in areas of high deprivation than there was in the other two groups, but similar across other demographic characteristics. And when we looked at the outcomes, so this is quite a busy graph, mothers of children with no long-term conditions are the reference group, the white circle. Mothers of children with a long-term condition that's not life-limited are the triangles, and mothers of children with a life-limiting condition are the black circles. And you can see here that there is a increased risk of depression, anxiety, serious mental illness, referral to mental health services. These weren't necessarily a surprise to me. I was more surprised to see the impact on physical health in terms of obesity, cardiovascular disease, high blood pressure, and unfortunately also premature mortality in mothers of children who had a life-limiting condition. We didn't see an increase in back pain, which was interesting because it was one of the first conversations we'd had around the impact on health and well-being in a parent who had significant back injuries, but her child needed a hoist, but the local authority wouldn't give her a hoist because her child wasn't 25 kilos, but her child was never going to be 25 kilos. But when we showed these findings to our parent group, they said, well, you know, if I get through to the GP, I'm going to be talking about my child. I'm not going to be complaining about my back pain. And I think this is, you know, some of the realities we need to think about when we're interpreting these data. So all studies have strengths and limitations. This is a longitudinal study, and the CPRD is a nationally representative data sample of primary healthcare data. We obviously can't be talking about causality because this is an observational study design, but we have demonstrated temporality and also dose response with key health outcomes. We are limited by the quality of coding within the data set, and some of the information and risk factors for cardiovascular disease, etc., such as family history, nutrition, etc., we didn't have information on. And as I've already said, unfortunately, it's not possible to identify father-child dyads within these data. So we showed that there are higher incidence of common physical and mental health conditions in mothers of children with a life-limiting condition, but we also need to understand parents' experiences of caring for their child and their own health and well-being. So I'm going to hand over to Victoria to start to tell us about that. Thank you.
Thank you, Lorna. I'll just share my screen. Thank you. So as Lorna discussed, there is an increased risk of mental and physical health conditions in mothers of children with a life-limiting condition compared to other mothers. And we were really interested in hearing about mothers' health from their own perspectives. So we conducted a qualitative study to explore their health in more depth. And in addition to this, and as part of my PhD, we also wanted to understand a bit more about the health and experiences of fathers, given the paucity of evidence surrounding their experiences in health. So today I'm going to talk about two separate qualitative studies that we carried out, the first around the experiences of mothers and the second around the experiences of fathers, both with very similar aims to explore accounts of health, experiences of accessing healthcare, and preferences for support. So I don't want to go over kind of time-wise, so this will be a kind of a very quick overview of what was two fairly big bits of work, capturing some really important and rich and interesting findings through speaking to over 40 parents who generously shared their perspectives and experiences and stories and children's stories with us. So some of the nuance might be tricky to capture in this very sort of quick overview, but I will link the published papers at the end for a bit more detail on that, and obviously happy to answer any questions. So in terms of the methods, they were very similar, both of the studies. The fathers also completed a short survey before they took part in a semi-structured interview. I'm not going to present that data today, but again, it's in the paper if anyone is interested. But mothers and fathers were recruited through children's hospices, hospitals, and through social media. They took part in online or telephone interviews that lasted between 60 and 90 minutes. The interviews were recorded and transcribed verbatim, and then the data was analysed using reflexive thematic analysis. We asked parents very similar things. So the topic guides covered family setup and caregiving responsibilities, mental and physical health, workplace issues, experiences of healthcare, and of course preferences for support. So 30 mothers took part between the ages of 32 and 60, and 12 fathers between the ages of 39 and 51. Their children, there was kind of a split between male and female in both of the samples, and the mother's children were between the ages of 1 and 23, and the father's children were between the ages of 3 and 23, and the children had a range of diagnoses. Again, if you're interested, there's some more demographic data included in the papers, particularly the father's paper, and they shared quite a lot of demographic characteristics through that initial survey. So I'll go on now to talk about the findings of the thematic analysis of the mothers study, and there were 4 themes from this analysis. The first theme surrounds the unique experience of parenting a child with a life-limiting condition, and mothers felt that the unique complexities and challenges that they had experienced could go unnoticed by others, particularly healthcare professionals. There was a lack of understanding or recognition from those healthcare professionals, which really led to a paucity of support in mothers looking after their own health. And this mother was talking about not being able to stand for the last 8 months and found it really difficult to get a GP appointment, and as Lorna touched upon, got through to reception at the GP surgery, but the priority was to renew their child's medication. So this mum found it really difficult to address her own healthcare needs alongside making sure that all her child's needs were met. If we think about mental health, mums felt that their normal reactions to difficult situations could often be pathologised. And so this mum said, I think I struggled with the concept that my thought processes were irrational. And sorry, I'll just have to move this little box so I can see this quote. Another mother kind of reiterated that, in that I suppose it is anxiety, but it's a different anxiety when your child stops breathing. It's reasonable anxiety. So this kind of dearth of appropriate support or recognition meant that many mums disengaged with health services for themselves. The second theme from the mothers' data surrounded their reluctance to prioritise their own needs. So this is less related to kind of a lack of appropriate support, and more that mothers just found it difficult to prioritise their health in the first place. There was a slight unwillingness to address their own needs in terms of healthcare and more general support that they might potentially have needed. And this was for a variety of reasons. They were worried about judgment from others. They felt they needed to be strong for others. So this mum is talking about finding it difficult to share her struggles with her partner because she didn't want to burden him if he was struggling as well. And importantly, mums felt that they didn't have trust in others to care for their child. And this mum says, not that I don't trust them, I don't trust their medical ability to cope in a crisis. So mothers didn't want to address their own needs and take respite from caregiving and take time away from their child because they didn't have that trust in others' ability to care for their child. And the middle quote there, I think, is really important, in that this mother was talking about being scared of going to the doctors because she didn't want them to find that there was anything wrong that then might mean that she needs medical treatment, and then she would be forced to take time away from her child, and she wasn't confident that her child would be cared for in her absence. So the third theme is around the stress that mothers experienced resulting from battles with services rather than as a direct result of caregiving. And this is something we hear quite a lot from our parent groups and from research participants, and Jules touched upon this in her presentation. Mums talk about the repeated battles, and it's those repeated battles and fights with services that causes the frustration, the tiredness and the exhaustion, and waiting for equipment, battling for equipment that they need in order to care for their child. So this mum said, not having the correct equipment is a big one. Because of COVID, things have slowed down. The sling is the most important thing in our house. We need it. She's a big girl, and as a result of us not having a sling, me and Dad have now got back problems. And we hear that parents will battle for appropriate equipment, and then by the time they get it, their child has grown and then needs a bigger bit of equipment, and the battle starts again. So the fourth and final theme from the mother's data surrounds establishing connections and feeling recognised. And I think this theme really speaks to all of the other themes, that when things go well and appropriate support is there, mothers can feel safe and empowered in caring for their child. I think particularly this bottom quote is important to read. Our social worker is great. I messaged her a few weeks ago saying, you know, my brain is not my own anymore. I'm scared. I need you to ring me. And this mother, just through having that connection and that relationship, really helped her to feel safe in voicing her mental health concerns. So now we'll talk a little bit about the themes arising from the father's data, and then I will sum up with some key points from both of the data sets. So there were 3 themes in the father's data, and the first theme surrounds the everyday precarity, or the precarious nature of fathers' everyday lives. And this came from the inflexible, uncertain and unstable daily routines that they experienced, with a real fragility, a real threat of collapse of routines. And a lot of this precarity came from sort of the inherent instability of life-limiting conditions, the child's life-limiting condition. But there was a lot of precarity in relationships, in work, in employment, and also kind of the added precarity coming from fear of the withdrawal of support or services. So it was that overarching sense of precarity in fathers' routine, in fathers' daily lives. And I think this quote here really demonstrates the kind of attention that needed to be paid to get those inflexible routines right, but then with a real sense of fragility. So getting her out of the house is really tricky and really hard work. You've got to preheat the car to make sure it's the same temperature as the room she was in. You have to run her out of the house like a rugby ball, through the outside and into the car. You have to hope that whatever room she's going into after the car is about the same temperature. Any failure in this will cause a seizure. I won't read this quote because I'm conscious of time, but I can always share my slides afterwards, or I think these quotes are probably in the paper as well. So the second theme from the father's data surrounds how they navigated distress they had experienced in the past, current losses and traumas and distress that they felt, and then how they managed that sort of anticipatory distress, fears about the future of their child's health and their death. So this is about fathers' experiences sort of across the course of their child's illness, and why it's so important to consider that there are different needs at different time points in their child's illness. This quote on the left says, I think the thing is that in the 5 months in hospital, we never had the chance to process what had happened, because you just tried to get from one day to the next. She was in intensive care. She had 2 respiratory arrests. She had 3 surgeries. You just get through from one day to another. And then all of a sudden you're back living in the real world, and it's quite scary. So you can feel the impacts of that experience going forwards. And one dad described his experience as trauma on trauma. So the third and final theme from the father's data surrounds the scope and the severity of the impacts of caregiving on fathers, and how there was a real lack of understanding and recognition from others around this, particularly healthcare professionals. And this is really similar to that first theme in the mother's data around those complexities and the uniqueness of this caregiving and parenting experience just don't seem to be acknowledged or recognised. So Dad's described some specific health concerns, particularly mental health concerns, such as depression and anxiety, but felt that they had a really unclear threshold for support. And actually those thresholds ended up being really, really high because they would put up with distress until support became urgent. So one dad says, I think I just pushed on and on and on to the point where I just couldn't keep going. It was like a fuse had blown. And another dad spoke about not being able to talk because dads are supposed to be strong for their family. As a dad, it's your job to protect your entire family. And he said, I think a lot of dads struggle with that. And then at the end, he said, you can only do that for a certain period of time before you cave in. So fathers felt that the support that they were referred to, such as sort of generic interventions like counselling or cognitive behavioural therapy, again, were just unable to recognise the complexity of their experiences. This quote in blue here, this dad described having a counselling session, and the counsellor suggested that he do some therapeutic doodling and get a pen and paper and doodle. And he said, I've told her everything, but I haven't got any tools to go away with. And the quote in orange demonstrates that this actually raises some safety concerns about those kind of short-term sessions. I found it quite painful, honestly, in that the 6 to 8 sessions available, that it wasn't really safe in the scope of such a short period to go into the depths of what was going on. And also in the time after the sessions, I would be less functionally available to the family because of what I had to go into and come out of. So I appreciate that was quite a quick overview. Sorry, this is a bit wordy, this slide, but just in summary, I've spoken about the precarity in fathers' experiences that goes further than uncertainty. It relates to the challenges associated with upholding those inflexible but unstable care routines. Mothers spoke about the battles with services, causing a great deal of distress, more so than direct caregiving itself. Parents really valued feeling recognised and understood by others. This often depended on individual relationships between families and healthcare support settings, but wasn't necessarily standard. Challenges across the course of the child's illness should be recognised. Parents' physical and mental health may fluctuate, and as may their support needs. And mothers again emphasise the importance of recognising the unique nature of this type of caregiving and parenting. Mums and dads wanted to be recognised and understood as parents and as caregivers. Support needs to be accessible and safe, and recognise this type of caregiving. Mental health concerns really need to be taken seriously, but in parents' experiences, the kind of generic interventions that they were offered often pathologised their experiences and tried to address or fix the wrong things. So, as Lorna said, the aim of all of this work has always been thinking about interventions for these parents. And initially we thought perhaps it would look maybe something like a psychological intervention, but having collected all of this data, we knew that it needed to be something much broader than that. So currently our work is adapting an existing carer support intervention called the Carer Support Needs Assessment Tool Intervention, or CSNAT. And this is a person-centred intervention that allows parents to identify, express and prioritise areas where they need more support. And really importantly, this allows parents to be supported in looking after their own health and well-being, but also to identify things that they need in order to care for their child. So these things, they can't be addressed in isolation. And just to mention another bit of work that we are working on, a body of work called Embrace, through which we're exploring the experiences of ethnic minority parent carers, their experiences of health, accessing services and preferences for support, because this is a really under-researched area. Thank you so much for listening. I've included the QR codes for the mothers and fathers study that I've presented, and then the QR code on the right there, the CSNAT QR code, is some initial work that we've done on adapting that existing intervention for use with parent carers, if anybody's interested. But thank you. I'll stop sharing, and go for questions.
Fantastic. Thank you, Victoria. Thank you, all three of you, for very powerful presentations. So I'm just going to look in the Q&A and see if anybody's posted any questions there. If you have questions, if you'd like to post them in the Q&A box, then I can ask them for you. But in the meantime, we've got some hands up, so I will go to Baroness Finlay. Would you like to take the floor? I think you're on mute.
Thank you. You've unmuted me. Thank you.
Apologies.
Really powerful presentations. The thing that struck me is that psychological support for the parents is almost a bit like icing on the cake if they can't get the basic physical issues sorted, like equipment in a timely way, like someone who they can trust, who can look after the child for a short time. And I am beginning to get worried that we are over focusing on providing psychological support and under focusing on the hard practicalities of providing care. And that quote about the hoist was very powerful. The quote about the parents who basically don't trust other people to look after their child, which I completely understand. I mean, I should declare an interest in our extended family. We have two now young adults, but with very severe difficulties. And, you know, I would be worried about looking after them on my own, actually, because one of them is so complicated. And that's within within our own extended family. So I worry that we need to be making a much stronger case for really timely support. So the wheelchair that's the right size, that comes rapidly, the hoist that is installed within 48 hours of it being needed, and so on, and adequate supplies to provide the physical support. I mean, I know, for instance, you know, of a sucker breaking down and then not being able to get a replacement one. Now, you know, that sounds simple, but it's a disaster if you're the parent of a child who's got loads of secretions and you've got to suck them out. So just, you know, thank you so much for doing this. The other question that I had relates just simply to other aspects of the parents. And I'm thinking about the From 16 questionnaire, which is a very short, quick questionnaire. I should declare it's come from Cardiff University, so I've got a vested interest there, I suppose. But I know that's been validated, but it's quick and easy, and it asks questions like being able to have a break and have a holiday, and about sex life and so on, questions that people normally don't address. But it seems to me that all that marital side just disintegrates when you've got a seriously ill child. And so you can't actually have a relationship with the person you're married to because the child's needs are so overwhelming. Thank you.
Thanks, Baroness Finlay. That's really helpful comments. I would entirely agree that I think we need to also be providing psychological support for parents as well as addressing the kind of meeting the basic needs of children. And social care is such a big issue here, and there's so much batting between social care and healthcare. That's a healthcare issue, that's a social care issue. The parents are not interested in who's paying for this. They want their child's needs to be met and also to be thought about in the future. You know, if you are taking time to do a full assessment, etc., then think about the fact that a child will look different in 6 months and in a year and etc. And part of the reason we've gone down from a research aspect of adapting CESNA is because it does address many of the things that you have identified. But I do think that psychological support is also appropriate and timely. Psychological support is also would be really valued by parents and children as well. I don't know, Jules, if you wanted to add anything.
No, I completely agree with you there. And I think, Baroness Finney, it was really nice to hear your appraisal of it all. And I understand. It's really good from a parent's perspective to hear that other people are getting it too, I suppose. But I would say that psychological support is going to be needed to support these families, because I think when they are asking for help within the community for things that they need for their child, they're often made to feel like it's their fault. And that makes asking even harder, I suppose. And that's why a lot of parents feel they have to find an alternative solution themselves, or just not get the support themselves. I was told that by one of the medical professionals in London that my husband and I were Fraserologists. That's how they've referred to us, which is a nice way of putting it. But it also, it sort of said, you know, nobody knew Fraser as well as us, which was true. But also, it kind of put a burden of responsibility on us to know everything about him and know what was to come as well. And we didn't. We really didn't. We were guided by the limited number of people that knew about his condition in the world that could actually help us. So I think had we have had psychological support really by people that understood the complexities of and the multifacetedness of living a life, which is very suddenly very different, literally overnight is very different, but also has multiple different areas that it affects: your job, your personality, your person, who you are, your family dynamics, your income streams, everything. Somebody that really could understand all of that would actually be really beneficial to supporting families, as well as, of course, addressing the practical side of things as well, in making the things that are requested by families happen a lot sooner and a lot quicker.
Wonderful. Thank you, Julie. So I'm going to move to a question that's in the chat from Marion, if that's okay. So Marion has asked, why is there such a disconnect between primary care services not understanding that a child and their family needs a hoist and they're not fitting the weight requirement?
I think that it's a local authority issue rather than primary care, I think. And again, it's just somebody at some point has written a document, and people are often constrained by what they are allowed to do. And I think Jules's example of kind of the competition that parents are meant to feel, you know, if we give you a full care package, then the child down the end of the street can't have anything. These are, you know, not uncommon conversations we hear. There are budget is one of the main things that drives a lot of these decisions, but also Jules made a really good comment about, whilst Fraser had a very unusual condition, his needs were actually not dissimilar to many other children with very different conditions. So we should be able to do better, I think, would be my short summary.
Absolutely. I responded to that as well, thinking that, yeah, that's the key thing, isn't it? The fact that the needs were more common and we should be able to address them. So, yeah. So I'm going to look at one more question from the chat from Cara, because that came in, and then I'll go to Francis on microphone. So question from Cara Bailey. The difficulty of navigating services is right across the life course. We hear it more and more in adult services too, and it's unacceptable. We need an integrated system for palliative and end-of-life care, which is for all and helps reduce the problems of children and young people transitioning to adult services too. Big challenges. Do we look at this as one system rather than separating children and young people, adults and older adults? Thoughts? Question mark. The big one.
How long have we got, Morag? I think it's really I think we have, you know, children's palliative care fits under the all-age palliative and end-of-life care programme. So in theory we should, but in practice we've just been having a discussion about social care this morning. Social care for children sits under Department for Education. Social care for adults sits under its own department within government. It makes it very difficult. I think as a starting point for children and young people, we could at least be looking at health, social care and education as one system for children and young people. That would be a very good start. There are examples in other parts of the world where they utilise, for example, adult palliative care nurses to care for children and young people in the community in Southern Ireland and in parts of Canada, which does in some way diminish the issue around transition. I think there is an issue with our registration and our ability to do that in the UK, but it does come with other, other challenges as well. So I think we absolutely should be taking a systems level approach to this, whether that's all age or just within children and young people. It's my relatively short answer.
Yeah, and the fact that it's this, as Victoria would said so clearly, it's the system that's causing a lot of the stress over and above the role of being a carer is just tragic. So I'm going to go to Francis, if you'd like to come. If somebody could unmute Francis. Nick,
yeah, I
Michelle,
think Francis should be able to
Okay.
turn on her mic or camera now.
Right.
It sometimes takes a little while to
Okay,
come
that's
through.
fine. Maybe while Francis is battling with that, I'm going to be cheeky and ask a question myself, which is to Victoria. So it's so interesting to hear about the sort of different concerns and needs of the mothers and the fathers. I wonder if you had any information or data on why they're different.
I think I'm not sure they are as different as I thought they might be. So a lot of the things that fathers were talking about in that third theme around the impact on their health and mental health, around a need to be strong for others and it's a dad's job to support others, that was completely there in the mother's accounts of I'm a mother and I need to be strong and I don't want to burden my partner with my concerns. So although fathers attributed it to being a dad and being a man, it was still there sort of throughout the parental experience of what our roles as parents are and how that went on to impact kind of ability to prioritize health was actually fairly similar across the mothers and fathers in these studies, in these samples. So although the mothers spoke more about the battles with services and dads spoke more about the kind of precarity and uncertainty, actually I'd say that their overall similarities shone more than particular differences.
Interesting, really interesting. I'm going to just check with Francis again if she's managed to unmute herself. If not, Francis, if you want to type your question in the Q&A box, then I can try and pick it up. While we're waiting on other questions, I wondered, either Lorna or Victoria, if you want to tell us a little bit more about the work you're doing in adapting SESNA-I, how you're going about that in order to make it work better for parents of children.
Go ahead, Victoria, you're doing all the work.
So the initial work around that has been, which is the paper that's linked at the end of the presentation, and I can share that afterwards if anyone's interested. So initially, the SESNA contains a number of domains of support, and our initial work was to map this data that I've just presented onto those domains to check that the SESNA captures the potential needs of parent carers. And actually we've added an extra domain around making sure that the child's educational needs are met, because that wasn't included in the original SESNA. And our next chunk of work will be some workshops with parent carers and healthcare professionals around how appropriate and suitable the SESNA approach and intervention is. So this will be conducted in children's hospices, and we're going to identify some key implementation challenges and so that'll be workshops in September, and then hopefully take it to a feasibility study in children's hospices following that kind of co-production work with parents and professionals. I don't know if Lorna wants to add anything else to that.
No, that's a really good summary. I guess the only thing that we've had hesitation about so far, particularly from staff, but also from parents a little bit, is what's the point in voicing if nobody can solve the problem? And it kind of comes back to the, the systems need to be in place to be, if a need is identified, for it to be at least an opportunity for it to be met in a timely and appropriate manner. We've chosen children's hospices as the setting because within the hospices they have more flexibility. They're not as constrained by some of the policies and practices that we have within our statutory services, and it will give us the opportunity to at least have a go at evaluating. But we do need to be thinking about what's happening in the rest of the system that enables that to have a chance to actually be successful.
Fantastic. I mean, it was striking to me that some of the similarities that there are with adult carers, which is the space where I do more work in, but there will be those unique differences, and particularly, as you say, around education. We've done some work recently looking at the appropriateness of CESNAT for young carers, and that issue of education has come up again there as an area that's not currently covered by the tool, because obviously the originators work purely with adults, which makes it understandable. Anything you want to add to any of that, Julie? Give you another opportunity to come in.
No, not particularly. I think both Victoria and Lorna have, explained everything very well, actually. And I'm interested to see how the next stage of research and evaluation happens, and the outcomes of those. And it's something that is shared within the support group parent forum that I'm part of within King's College, which is fantastic.
That's great. It's fantastic to have that support. So we've got a hand up from Oluwesi. If you'd like to come on, Mike, as poor Francis, I think, is still doing battle.
Yeah, hello, thank you. Thank you so much, Lorna and Victoria, for the really interesting presentation. My question is just around whether anything was mentioned about challenges with finances from the fathers and mothers. But some of the work we've been carrying out at Evelina Hospital suggests that this is also an area of great challenge for parents. A lot of them, for example, do not know about the existence of benefits like the DLA. So I just wonder whether you want to throw more light on that. Thank you.
Victoria, do you want to go?
I think particularly the fathers spoke about, we didn't talk too much about financial challenges, and that might be to do with the demographics of the samples that we recruited. But the fathers particularly felt a great deal of responsibility to make sure that things were going well at work, often to ensure that they were still able to financially support their families. And this wasn't across the sample. There was a couple of examples where that sense of precarity that came from fathers' experiences of employment was really to do with, if I lose my job, my family will not be financially supported. I can't think of anything that I discussed with mothers about finances. Lorna might recall.
Yeah, we weren't focusing on that. I've put a recent paper we've published about the impact of end-of-life care adijoki, which highlights exactly what you've said. And we've also got a PhD student who's just started looking at economic impact and how we think about measuring informal care costs in this population, because again, it is actually quite difficult to think about. You have to really think systematically about the impact. This is, there's lots of things going on about ability to earn, employment choices that Jules has already mentioned. And I think the other thing to think about is this is often very, very long term. Many children and young people are now living into young adulthood because of advances in acute medical care. So the cumulative impact is for some families is likely to be quite significant. I'm really pleased to see that Francis has managed to unmute though, so I want to give him the chance.
Absolutely, I was just about to cheer. So Francis, the last question is for yourself.
I just wanted to say thank you. I think this has been tremendous. I think it's a tremendous piece of work. But I also want to say there's nothing new here. We've known this for years and years and years, and nothing seems to change. And that, for me, is the real issue. How do we address that? And just going back to the psychology kind of care question earlier on by. For me, I think if we can address some of the physical, some of the care issues, that enables and sets the parent freer to address some of the psychological issues that they might want to talk about. And they spend most of their time having to rush around talking about those care things, which doesn't give them the opportunity to concentrate on themselves. And I think, how on earth do we address that? I also wondered whether, coming out of this work, I mean, there was some references for parents to do some work, but I wonder whether there could be something for GPs around checklists to ask parents whether they're taking care of somebody. I also wondered about the bereavement aspects and whether there'd be any follow-up work around those mothers and their bereavement experience. I think that's really, really important, and how that might affect both their physical and their psychological health after. And I just wanted to say to Julie, thank you so much for sharing your story. And you won't know this, but in actual fact, I was on the board of trustees who designed and developed Christopher's many years ago. And it was
That's wonderful.
Great delight to see that. Very, very sad to hear that services are being reduced. Now, this is happening right across the hospice sector, and I think that's another important issue that this work could actually help with informing that debate. So thank you all very much indeed. It's been really, really helpful.
Can I come back quickly on that, Morag?
Very quick.
Just thanks, Francis, for continuing to champion from the very north of the UK. We are moving towards developing and adapting interventions, because you're right, we do understand a lot of the problems, but that's where we're going next. And I could answer in more detail, but I'll let Morag wrap up. But thank you for your contribution.
Yeah, I was just going to say something very similar in that, that my last 30+ years of working in this field, we have just got to move beyond identifying the problem and coming and dealing with the solution, which some of us are starting to do, which is so good to see. I've put a link in the chat to the overall website for SESNAT if anybody wants to see more about that. So if I could just ask you to join me in thanking our incredible set of speakers today, and thank you for everybody's questions as well. So thank you particularly to Julie, but also of course to Victoria and Lorna for joining us today. And to let you know about the next webinar that's coming up. So I think Nick's going to share a slide. So the next webinar will be Tuesday the 16th of September, and we have a session on timely access to end-of-life medications, which is being chaired by Ben Bowes from Cambridge, with speakers, a range of speakers from the field. And just to let you know that if you want to access recordings of previous webinars and learn about the work of the national collaboration, then you can find that in the link that's at the bottom of this slide. And I suspect someone will put a link in the chat as well. And then very finally, before you all disappear, we are really grateful for any evaluation and feedback on this webinar series. So there is a link there to a Mentimeter, so you can give us any comments or suggestions, or you can use the QR code to give us any feedback. And we're particularly keen to hear ideas for future webinars, which you don't have to lead yourselves, but if there's something you'd like us to look into organising speakers for, then we can do our very best to do that. So just to once again thank our incredible speakers today for their time and energy and for sharing the work they've been doing, and from Julie for sharing her experiences, and thank you to everyone